called VNA Hospital. This is at Navjeevan Vihar, 1 Navjeevan Vihar, and it's a multi-specialty place. Though we do a lot of urology and andrology practice here, and that's been my interest. So we'll quickly begin with this. Now, when we talk of evaluation of male fertility or subfertility, we know that it's extremely common, unfortunately still quite neglected. We'll kind of skip these slides, but see the main factors influencing the prognosis. And a lot of times couples these days come in, they've got married at 40. I had this couple recently, they were married at 40, the guy at 45 and his wife is about 43. And infertility now is a completely different ballgame compared to what infertility would have been a decade or 2 decades ago. So you're looking at whether they've been married early, what is the duration of infertility, whether it's primary or secondary infertility, what are the results of the semen analysis if it's been done for once, or if you've had more than a single report, what's the age and fertility status of the female partner. And all of these factors will influence the prognosis of fertility, infertility. And when we look at evaluating a male, we're looking at immediately, is this someone, since we define infertility as someone who's had unprotected intercourse for greater than a year and other factors having remained normal, they've still not achieved fertility. We're looking at whether this is something that we can reverse. Are there reversible factors involved? Is this medically treatable? Is there a surgical option for correction here? Is there really nothing that we can identify and we will presume, or we will refer them for further management by ART experts? And do we have a cause here, or is this something that will fall into the larger group of idiopathic male subfertility? Very important in the history, right at the start of the history, to realize whether they've had regular intercourse or not. Unconsummated marriage is very common in our region of the world, but also infrequent intercourse, because that's something with the current lifestyle which is so common. And we come across couples, even educated couples, they say we meet once a month when she gets her off from Bangalore and I come in from Mumbai, and we meet and we have intercourse once a month. And it's important to make them understand how the frequency of intercourse will affect the outcomes and the probabilities of having a offspring or pregnancy. Ejaculatory disturbances, again, fairly common with erectile dysfunction also as a cause of infertility, and we find similar factors in young males, stress being the leading cause for both ejaculatory disturbances and erectile dysfunction. And a lot of couples will use lubricants without understanding what effect these lubricants may have. And again, important in the history to identify that. There are certain things which can also be identified from history, such as history of bumps or some surgeries, undescended testes. Again, young men having used or abused testosterone or anabolic steroids for their bodybuilding in the gym. Other drug abuse, fairly common now. You get these men who use these various recreational drugs and their effects on semen analysis. Smoking, extremely common. Now with COVID and other illnesses, it's important to identify a recent febrile illness so that you know that if there's a sudden variation in the semen analysis, it's something that you would tend to repeat after that cycle of spermatogenesis. Again, partner history important, remembering that fertility is never a single issue, it's always a couple issue, and we would be interested in knowing if there are previous failed ART attempts, history of miscarriages, because then you're looking at both whether it's the male factor that's causing these or the female factor. And certain things that are not so clear, but we tend to tell them to avoid these when they're planning fertility. When we look at a man coming into the OPD, we already start looking at him with certain things in mind. Are you identifying developed secondary sexual characters? Is he obese? Is he tall? Is he got a normal testicular volume? When you start examining him, is the vas present or absent? Is the epididymis soft, normal feeling, or is it turgid and nodular? Is the cord normal or thickened? Is the scrotal skin thickened? Is there varicocele? And if so, what is the grade of varicocele that you identify? Very rarely we subject them to a rectal examination. We rarely do it. If we've got someone who's come in with a particular difficulty in ejaculating, saying that he always has only few drops of ejaculate, the vas is very well palpable, he has a report of azoospermia, you may consider ejaculatory duct obstruction and then do a rectal examination to see if it helps you. Semen test is the surrogate marker of fertility for the man. Very wide variability. The optimal, again, the WHO says that you can have an abstinence of 2 to 7 or 2 to 10 days, but the optimal, you want to keep a defined number. So it's practice to generally tell the man one particular period of abstinence. My habit to tell them to have 3 days of abstinence before we ask them to give a sample. In azoospermics, it's not so important to have this abstinence because you want to essentially know whether there is cryptozoospermia, whether there is any possibility of finding sperms. And then if they've come in, then it's not mandatory that you've asked them to have this abstinence period. Again, when you're looking at certain things such as DNA fragmentation, when you want to have that lowered, you can look at a shorter abstinence period. It should be collected in a wide mouth sterile container. Important also to ask when you see the report whether there's been spillage, because men tend to ignore the fact that if they've dropped the initial few part, which is actually the sperm red part, they will tend to ignore and even forget to mention to you that they spilled some of the semen. So important to ask them here. Again, important to know these guidelines for semen collection. Preferably have a room for semen collection with the standard abstinence that you would have. Let it not be an extremely cold or uncomfortable room. Complete sample should be collected, and if there's any loss, that should be reported. Very common to have failure to produce sample on the day of egg pickup. This happens time and again. And you can also have things like retrograde ejaculation or paraplegic who knows that there's failure of emission and so sample cannot be produced. There's always a history of difficulty in sample collection. You may advise home collection, or more commonly we tend to have a vibrator in the clinic which allows them to give the sample in most cases. Again, remember, vibrators are of different variety. The ones which are useful for ejaculation are the ones which have these high amplitude vibrations, best given to the undersurface of the glans at the frenulum. That's the most sensitive area which will result in the ejaculatory reflex arc to be stimulated and then to have reflex ejaculation. One question that is always asked is, what if the man has erectile dysfunction? It actually don't require an erection to stimulate the ejaculatory reflex arc. And so it's not mandatory that he has an erection. You can do the vibrator, penile vibrostimulation even without, in the absence of an erection. And collection into a non-spermicidal condom. These days there is another kind of vibrator which is available, which is actually something that allows the man to have this vibratory stimulation over a penetrative act, because that vibrator is shaped like a vaginal orifice, and a non-spermicidal condom within that allows the semen to be collected. This is a Vibrect device. These days it's become a little difficult to procure, but otherwise a useful one, because the Vibrect X3 would allow a high amplitude vibration to induce ejaculation. Again, amplitudes of greater than 2.5 mm allow ejaculation. If this doesn't work, then something that can be used particularly for paraplegics is a electroejaculation. This is done under general anesthesia, requires adequate lubrication. Empty the bladder, because a lot of times urine tends to also get released with the ejaculate, and if you've not alkalinized it, then you would have difficulty with getting a good semen or good sperm sample. This is a probe which is inserted rectally, and stimulations are given on sequential basis to allow ejaculation, again by stimulation of the prostatic plexus around the prostate. Now, what do you do? What do you look at when the semen report comes to you? We're looking at the volume. Now, these are things that are missed quite often, but they give very important information. So, it's low volume or normal volume, acidic or alkaline. These two factors are missed a lot, but they give us very valuable information. Should be done very carefully. Viscosity, agglutination, fructose, count, concentration, motility, morphology, and vitality. So a lot of times you'll get these kind of reports, and you can make out straight away that they've not looked at things particularly. These are not standardized terms. They don't tell you a report according to the recent WHO guidelines or even the older WHO guidelines. So this is a report that I'll tend to ignore and repeat a test, because this actually does not give me too much information. It tells me that the person who's doing this is probably not well versed with the WHO guidelines for semen examination. And you'd want a report which is far more informative. So you could have it as informative as this, which actually breaks it into different centiles, which is good for counseling the patient in case you're planning on treating the patient. But otherwise, even simply, you would need to have a report which would give you things such as whether there's any medication being used, whether there was any difficulty in collection, whether all of the sample was collected or not, how many days of abstinence was there, and then the other factors in the semen findings. So the current 6th edition, we've moved back to discussing rapid and slow progressive motility. This is actually an older from the 5th edition, I think. But we've moved back to the difference. I'm not going into the details of how the semen analysis has changed, but broadly, some of the differences that came in the 5th edition have now been addressed in the 6th edition, and it's a more broader population covering semen analysis report, or something that gives us a more broader cover of group of patients, and so probably more relevant to us. When would you do a hormone analysis? Now, as per current guidelines, if the counts are greater than 10 million per ml, then hormone evaluation is irrelevant. The counts are less than 10 million per ml, then doing an FSH and a total testosterone should usually suffice, especially if they are normal. If you expect hypoandrogenization or erectile dysfunction, then an LH could be added. If there is loss of libido and erectile dysfunction, then a prolactin test would also make sense. Estradiol in obese men, where you're looking at the testosterone estradiol ratio. These days, we've also started adding a 17-hydroxyprogesterone, especially in men that are suspected of having non-obstructive azoospermia, and inhibin B is a plus-minus factor. Both of these have different roles. The 17-hydroxyprogesterone to give us an assessment of the intratesticular testosterone values, and the inhibin B to tell us whether there is any chance of sperm retrieval when we are attempting a micro-TZA in these men with non-obstructive azoospermia. Ultrasound, unfortunately, is used as a tool to skip physical examination. That should not be the case. Things such as absence of vas deferens and varicocele are only and only identified and treated on basis of clinical examination. But you may do a scrotal ultrasound prior to surgery and a transrectal ultrasound in the case of ejaculatory duct obstruction. The use of abdominal ultrasound is limited to cases of unilateral absence of vas deferens, where you will also get a unilateral renal agenesis along with. Advanced sperm function tests, controversial as to what all you will use, when you will use, but now I think we are getting them in the guidelines that in couples where you're facing recurrent pregnancy failures, recurrent miscarriages, recurrent implantation failures, you look at other factors which may be involved, and DNA fragmentation, high DNA fragmentation may be something to look at there. Ideal to get a tunnel or a comet test, which are supposed to be higher in terms of sensitivity. But a commonly used test is the halo sperm, and that's easy to use, though there's subjective variation. My assessment is that if the observer is the same, which means if you keep the observer constant, then you can avoid the inter or the intra-observer variation and get reasonably accurate reports for follow-up. So say you start with a certain DFI based on the SCD. If the observer remains the same, you could possibly assess whether whatever intervention you brought in resulted in any improvement or not. Oxidative stress testing, far less common. We had myoxis for some time, but we had problems with procuring strips, and so we don't have much experience with that, but you could use that or some other strips which are based on chemilucents, but not very commonly used for male fertility. So would you do DNA fragmentation or oxidative stress testing for primary evaluation of infertile male? No, it's essentially indicated for recurrent pregnancy loss, ART failures, poor implantation, poor embryo quality, unexplained infertility, or if there are additional male risk factors such as a very large varicocele, genital infection, smoking, advanced age. When would you do genetic testing? Obstructive azoospermia due to vasoplasia, non-obstructive azoospermia, oligospermia less than 5 million per ml count, or recurrent pregnancy loss. These are the indications for doing genetic testing in male infertility. And when you have vasoplasia, you would do a CFTR assay, a panel for CFTR assay, both in the husband and the wife. And that would also, if the wife has the carrier, then they need to counsel the couple regarding the risk of cystic fibrosis. And in non-obstructive azoospermia, the two tests that are recommended include karyotyping and VQ microdeletion. And as a single test, the most important test that I always advise everyone is the VQ microdeletion, because if you have a AZF-A or AZF-B VQ microdeletion seen, then the chance that there is any focal sparing spermatogenesis still present is nil. And so the utility of a retrieval procedure such as microTSA is not there. And so it is not indicated then to attempt any retrieval procedure in such men. If significant seminal leukocytosis is accompanied by lower urinary tract symptoms, then a semen culture or a post-prostatic massage urine culture is indicated. Most common infection is chlamydial, which requires a PCR for diagnosis, and most chlamydial infections are treated on an empirical basis. If there are lower urinary tract symptoms, or if a bacterial prostatitis or a bacterial infection is identified, then treatment according to sensitivity culture is appropriately used. Most commonly, quinolones are preferred here for use in seminal infections. The point to make here is that seminal infections are reported far more often than they actually occur, and it's important to have this thing in mind when we are treating for seminal infections. In fact, the use of antibiotics or the rampant use of antibiotics during ART cycles is known to hamper the outcomes, and so we must be very judicious in terms of how we are going to treat seminal leukocytosis, which is insignificant, versus that which requires antibiotic therapy. So that's an algorithm for evaluation of urogenital infection. In the presence of infection, especially when you have symptoms, you will follow it up with further tests, the post-prostatic massage, first void, and the post-prostatic massage urine test, the 2-class test or the 4-class test. And if you've seen increase in leukocytes in the post-massage urine, or if uropathogens are positive, then you treat according to sensitivity. And if you don't have symptoms, you're looking at other causes. and here you may end up with ART straight away, or again, if you look at certain factors in semen analysis which are positive, you may look at treating with antibiotics. But here the index of suspicion for other possible causes or other forms of treatment should be higher, and the use of antibiotics should be done more discreetly. A diagnostic testicular biopsy is rarely required. What we call this is a therapeutic trial needle aspiration biopsy, which is done in cases of equivocal clinical findings of obstructive or non-obstructive vasospasmia. So it always has to be done where a facility for cryopreservation is also available. This is also done at the time of a anastomosis for VEA to demonstrate spermatogenesis. Prior to that, we do it as an intraoperative procedure, actually to know the exact site of spermatogenesis, so that the anastomosis is done to the site of where sperm production exists, and rarely it can prognosticate. So we don't use it as a prognosticating test, but if available, then it helps to prognosticate whether we are likely to find sperms with a more aggressive micro-TSA procedure in azoospermics. Thank you for your kind attention. Any questions we can take?
Thank you, sir. That was very elaborate and important points you have focused, I think, because we all gynecologists lag on that part the most when treating an infertility couple. I think, any comments from the experts?
Sir, I would like to know the test which you just said, 17-hydroxyprogesterone. Can you elaborate how it will help?
So, one of the very recent data which has become available, actually it was there for some time, but now being used far more frequently, is that 17-hydroxyprogesterone is the closest marker for intratesticular testosterone production. So now